So we're going to discuss what to do when you have refractory Barrett's esophagus, and what of course we mean by that is when someone's been diagnosed with dysplasia of their Barrett's, and what you're trying to do obviously once you have resected the visible nodules is trying to remove or ablate most commonly the remaining Barrett's esophagus so that you decrease their recurrence risk. There's a nice study from the Amsterdam group called the AMC marker study which demonstrates that after ablative therapy you turn the genomic landscape of the Barrett's esophagus from high risk with things like P53 positivity back to a lower risk form. So clearly the ablative step is very important in terms of the long-term prognosis of these patients. Now, radiofrequency ablation is well established, well tried and tested, and has great data to show it's highly effective. And in the vast majority of patients, radiofrequency ablation is the first line therapy for performing ablative therapy of the Barrett's and getting rid of the residual disease. But clearly there are a very small percentage of patients who actually, despite appropriate treatment with radiofrequency ablation, still have refractory Barrett's and still have Barrett's segment left and ongoing metaplasia, or even sometimes dysplasia. Now, the definition of refractory Barrett's esophagus varies really according to what manuscript you read or what study you read. Probably a good rule of thumb is to say that if the length of Barrett's esophagus hasn't reduced by 50% despite 2 or 3 treatments, that's probably verging on refractory Barrett's esophagus. Certainly after someone's had appropriate treatment and they still have Barrett's remaining after 3 or 4 occasions of radiofrequency ablation and biopsy show there's still residual metaplasia dysplasia, that's definitely refractory Barrett's esophagus. At that point, when you suspect that someone might have a refractory Barrett's esophagus, first thing you really need to do is make sure that they're on appropriate acid suppression. We know that patients who don't take their PPI, their ranitidine or their sucralfate or whatever your sort of local regime is for post radiofrequency ablation therapy, if they don't comply with that medication, they're highly likely not to get great success in terms of getting rid of it. So first thing you should always ask these patients is, are they taking the medicine appropriately? Because often you'll find quite a good percentage of them just simply aren't taking it. However, if they are then defined with refractory Barrett's esophagus, which is not responding to radiofrequency ablation, then you have 3 main therapeutic options. We have 2 nice examples on the site of 2 of them, so I'll talk about those in particular. The third one that I won't talk about so much right now is the use of hybrid APC, which does have some good data on them. The 2 videos we have on our site now are Cryotherapy and the Endervoter. Now, cryotherapy is essentially using cold instead of heat to ablate the Barrett's esophagus. Now, there are studies going on at the moment, particularly the cold plate study, looking to see whether this could be first line in ablative therapy, so instead of radiofrequency ablation. And the rationale behind that is that there is theoretical possibility that cryotherapy will reduce stricture rate and also reduce pain post-therapy as well. At the moment, those studies are ongoing, so it's still not first-line therapy, but it is being used for patients who have refractory Barrett's esophagus. Now, the video you'll see will show that actually in order to apply the cryotherapy, essentially a catheter is inserted down to the esophagus, a balloon is inflated, and then you direct the nozzle of the cryotherapy balloon towards the target and fire for 8 seconds. There is data to show that this does eradicate Barrett's esophagus and residual metaplasia in a good proportion of these refractory patients. So certainly that is one of the options we have in our armoury. The second option is that of the Endervoter. Now, they call this a cold ablative technique, but actually really it's more of a resection technique in my opinion. But essentially this is a device that has a twirling blade on it essentially that will remove the layer of Barrett's esophagus. There are again studies looking at whether it can be used for first line therapy, and actually those studies, very small amount of data at the moment, but those studies do show it has quite a low stricture rate, so that's certainly something we'll see develop over time. But for the moment, again, it's being used for refractory Barrett's esophagus, and there is a study again going on at the moment looking at ablative therapies versus this cold ablative therapy or Endervoter to see which one is better for these refractory cases. The other thing, and this is where I think Endervoter really is very effective and really that I think that a game changer to a certain degree, is in patients in whom you have visible nodules who have quite often undergone previous radiofrequency ablation or previous treatment, who then unfortunately develop a nodule further down the line that you see as visible dysplasia. When people have undergone previous therapy, what happens is you get a lot of scarring, and unfortunately those nodules can sometimes not lift, and you aren't able to perform an EMR. And this previously created a huge treatment dilemma, because at that point you've got a patient who you can see visible dysplasia or even perhaps early cancer, but you can't lift it and EMR it. And we know that an ESD would be extremely difficult in that circumstance as well, because of the amount of scarring. This is where I think the Endervoter is superb, because it provides that treatment for these refractory patients, where you can perform a submucosal injection to slightly lift the lesion as best you can, and then the Endervoter then chops up the lesion and gets rid of the visible nodule. Very, very effective. We use it regularly. The only thing that is different really with that is obviously because it's not a specimen, you can't get a histology report telling us that you've got complete resection or what your resection margins are, but certainly the histology report will tell you what you've resected, i.e. is it dysplastic or non-dysplastic. And of course then what you do then is you go back and check 6-8 weeks later to make sure the site looks much better. So those are the two examples we have on our site. Have a look at the videos and see the way they're used. They're both very effective for refractory Barrett's esophagus, and I think this is a real interesting area of development.